For our speaker, I'd like to introduce Dr. Olivia Schumann. Olivia is a clinical ethicist at Norton Healthcare and assistant professor in the Department of Philosophy at the University of Louisville, where she teaches students in the Master's in Healthcare Ethics. She has a background in anthropology and philosophy and completed a 2-year fellowship at Baylor College of Medicine in clinical ethics. Her research interests include social, personal, and symbolic aspects of medicine, as well as ethical questions around reproduction. Thanks for joining us today, Olivia.
Thank you so much. Okay, good morning, or good afternoon, I guess. So once again, I'm Olivia Schumann, and I'm really grateful to be here today. Thank you for having me. We're going to be discussing reducing bias in your chart notes. And I'm going to kind of follow up with a little introduction about myself, because I don't believe I've met many of you. And then we're going to talk about the Open Notes mandate and how it affects the patient chart, and what the patient's story is, and how that might be a factor in bias in healthcare. And then we're going to cover 3 cases of bias, and I'm going to go over some of the strategies that we'll have discussed throughout these cases. And then at the end, talk about how to contact ethics. So, yeah, so as Dr. Jennings mentioned, I'm a professor at the University of Louisville, and I'm also a clinical ethicist. So that means that I had training after my PhD. I had training at Baylor College of Medicine for 2 years in clinical ethics. And so my current role at Norton, I help manage ethics projects, improve ethics education and quality, and also do consulting as an expert on ethics cases. So in 2021, per federal rules, the 21st Century Cures Act was implemented. And this had an open notes mandate, which meant that patients or their representatives can now view their records, their medical record, in real time. So of course, patients have been able to access their record for some time now, but this is substantially different because it removes a lot of the delays, the barriers, restrictions, and gives them a range to a whole range of things in their chart. And this is done with the intention of transparency. And in doing so, it has changed the electronic medical record from a communication tool between providers to now a communication tool between provider and patient. And this has, of course, many benefits to patients. As mentioned, it proves transparency, but also self-advocacy. So a patient now, knowing that they don't have to retain all the information at once when they are speaking with, sorry, I'm going to move my webcam on it. Okay, sorry. So when they're meeting with the physician or the providers, they don't have to retain all the information at once. They can go back and look at their chart notes. They can process it later with their support network. They can search information after their session with their provider and think of questions they want to prioritize, questions that they have. So it allows for a lot more self-advocacy in their treatment. However, there's also risks to the patient. So of course, they might misinterpret information that is there. And they also might read information that they consider judgmental, upsetting, or harmful. And this is something that we're going to focus on more today. So everything that you put in the electronic medical record, it becomes part of the patient's story. So the patient record frames the story for everyone who reads it, including all of the clinicians currently working with this patient, future clinicians who might be reviewing this chart, and also the patient and their family that are reading. And how does this happen? How is this patient story framed? Well, it's about how things are written. It's about what is emphasized in the note. So what do you write first about the patient? What does someone see when they first look at it? What is in all caps, or in bold, or repeated either throughout the note or along various notes? It's also a matter of word choice. So there can be antagonistic word choices. For example, patient demands versus patient requests something. We're also going to talk about some infantilizing language or dominating language. There's also, we can frame things in terms of what's prioritized. Are we discussing the patient's weight rather than an issue that they came in to discuss? Framing also happens by what is missing, what is lacking, a lack of descriptions, a lack of context or explanation, and something that is not noted can also frame the context. And how are words interpreted? How are things that the patient said or the provider said interpreted, reworded, and quoted in the chart? And the patient story is so important because it tells us whether this patient is a good patient. Are they good to work with? Are they deserving? Are they worthy? And should their concerns be taken seriously? And if they're not viewed positively, then this can have further negative impacts on them. And a lot of this framing is done unconsciously, and thus it can really rely on bias. Fortunately, this is also something that we can consciously cultivate to try to hone our notes to be more in line with what we'd like to portray. So what is bias? So I know that this is a term that many of us have heard, and specifically here I'm thinking of bias in the sense of the tendency to favor one group over another. So this can be favorable or unfavorable. It can be a conscious bias or an unconscious bias. And it's the unconscious or implicit bias that's especially interesting because it's something where your actions reflect something that you consciously are in opposition to. For example, you really value equality, but your bias, your implicit bias, your actions reflect the opposite of that. And this can encompass things like race and ethnicity, gender, socioeconomic status, age, weight, persons living with HIV, disability, persons who inject drugs. Their studies have shown that physicians and nurses, when they have implicit bias towards their patients, and that this can affect their clinical judgment. And according to the National Academy of Medicine, bias, stereotyping, and prejudice are playing an important role in persisting healthcare disparities. Here are some consequences of bias. Bias can lead to lower standards of care. So women, for example, are 3 times less likely than men to receive knee arthroplasty, even when it's clinically appropriate. So this is suggested that this might be because it's assumed that men will benefit more from arthroplasty because they engage more in physical activity, or also it was suggested that men might be more stoic, and so they don't express pain as much, and so they're more likely to receive this. There's also bias that can result in harm. I mean, all of these things are harm. We have Black men are less likely to receive chemotherapy and radiation therapy for prostate cancer, and are more likely to have this. There's bias that can lead to higher mortality. And this, sadly, is quite well known now that maternal mortality in the United States is 5 times greater for Black women than it is for white women. And this disparity is related to non-biological factors such as stigma, systemic racism, and socioeconomic factors. And so providers, even when they're well-meaning, they may think of themselves as neutral observers, neutral writers, that this certainly couldn't apply to them. But the evidence suggests that healthcare providers exhibit the same level of implicit bias as the wider population. And this is also potentially heightened by the fact that with uncertainty and time pressures that providers face, they may increasingly rely on stereotypes for decision making. And so we have to recognize that no one is a neutral and objective observer or writer, And we all carry with us personal triggers and backstories and prejudices that can impact thinking and actions. And this bias that we have can make its way into the chart. But as I've mentioned, fortunately, there are ways that we can become more deliberate in our choices, and so that our writing is more in line with the values of quality and respect that we want to promote. Okay, so we're going to move on to the cases. So these case studies are based on work done by Laura Guidry-Grimes and her colleagues. So I wasn't a participant in these cases. So these are all from their work. So case one, so this is what the chart note read. So this was a compilation of their cases, and this has been de-anonymized, and some of the, identifying characteristics or aspects of it have been rearranged. I've also added a few things. So they did a review of the chart, and this is the thing that they found in the chart. Mr. Price, 52-year-old male, is demanding a change of prescription. Mr. Price is a frequent flyer. I worry of the limited benefit given that he is continually non-compliant. He seems to understand, but is uninterested in being helped. So what kind of story does this paint about Mr. Price? What do you think it sounds like that he will, would it be like to work with? Does it make him sound like obstinate? Does it sound like it'll be pointless to work with him? There seems to be a kind of negative judgment here of Mr. Price. Okay, but let's see what was actually happening behind the scenes. So he is concerned about the side effects of medication impacting his sleep. He currently is financially insecure and housing insecure, and he lives out of his van. And this has made it really difficult for him to keep appointments, to take medication regularly, or to follow a diet. It also means that he comes through the ED often for medical care. And the team has been counseling him to get better insurance so that he can qualify and receive better care. But that would require him to have a mailing address, a computer, and internet, none of which he has access to, especially because this was during the pandemic. So options for that were even further limited. So everything that they recommended for him did not work for him, and that's where the chart note that you just saw came from. Here are some improvements that could alter this note. So Mr. Price, 52-year-old male, is requesting a change in prescription due to concerns about sleep. He is experiencing barriers to following the medical regimen, which we discussed today, including Mr. Price has been adherent with, and after talking with him, Mr. Price indicated his needs have not been met yet, and the pandemic has been making the situation more complicated, specifically. So the changes here, so you see in the first one, he's requesting rather than he's demanding this change. And the change here is that we've also added, been more specific. Why does he want this change? Well, it's because he's concerned with his sleep. What are his reasons? That's really important to add. And with regards to his, it's not that he's just being non-compliant, it's what are the barriers that are standing in his way? And also talking about this, using this partnership language is what we discussed, and being specific about that. And rather than viewing the patient as simply non-adherent, what is the patient also adherent with? What are some of the positive? Patients adhere and don't adhere to a number of things. It's more accurate to represent also the things they adhere to. And after talking with him, Mr. Price indicated his needs have not been met yet. And so talking about specifically, what are the social determinants of health that are impacting this patient? And social determinants of health are things that are non-medical factors that influence health, such as physical environment, employment, social support, education, and socioeconomic factors. As we know, these are huge factors in patients' ability to follow through with care. And so this is to emphasize that when you're documenting, think about why. Why is the patient deciding this? Why is the patient not adhering to this? Why is this what the patient wants? Give context. Maybe it has something to do with their past medical use of this medication, or they have certain kinds of priorities. They want to save money for something. They're worried about something. Give this kind of context. This helps the next person reading it give them a fuller picture. And it also treats them as reasonable individuals with agency who are potentially facing difficult circumstances that are impacting them. And as I mentioned, when you're talking about non-adherence, framing it in terms of the barriers takes the blame off of the patient, rather than seeing it just a non-adherent patient as that label. What are the factors that are contributing to that? And being able to understand this is essential for being able to partner with the patient, which is the goal. And it allows you to turn this power asymmetry between you and the patient into this opportunity to actually advocate for the patient. Okay, case 2 is Miss Roberts. So Miss Roberts is, this is what the chart note reads, is that she is a 45-year-old female. She is undiagnosed and untreated schizophrenia and has been getting in trouble in the community. Delightful, but refuses everything we offer her. I have explained her options to her. Patient reports that I ain't gonna do it. Okay, so again, what does this evoke about the patient? What is our assumptions that are built in already by these limited things that we've read? It's also kind of an odd note, right? Seeing that she's delightful, but also been getting in trouble. And she has both an she's undiagnosed schizophrenia, but then they're also giving a diagnostic term. It's kind of unusual. And why is it relevant that she's getting in trouble in the community? Why has that been added to the chart note? What is that doing here? So behind the scenes, what happened is that Miss Roberts, she came in voluntarily. She had a broken jaw after being assaulted, and she is declining the surgery because she is afraid of anesthesia. And interestingly, there's actually no documented psychiatric history in her chart note. What had happened was that they had asked her who they wanted them to call on her behalf. And she said that she knew a parishioner, and she gave the number. And when they called this parishioner, he said that he believes that she has an undiagnosed and untreated bipolar disorder, and that she is a druggie, and that he wants nothing to do with her. And so the opinion of this person was put in the chart and front and center, the very front of her chart, and repeated for the 13 next notes without there being any basis for the claim. And also potentially, of course, biasing the people who are reading the chart note against this patient. So here are some improvements to the chart. Miss Roberts is a 45-year-old female. We have discussed her options together, and she's currently declining surgery because. So again, this is the partnership language we have discussed rather than I've told her, and giving the reasons why she's doing something. And Mr. Jackson stated he does not wish to be involved and should not be called again. We don't have to go into what Mr. Jackson called her and these labels that will then be repeated throughout the chart. He doesn't want to be involved. He's not someone to refer to, so that we can just say that. So what we've done also is we've removed some of the infantilizing language. So calling someone delightful, unless they're like a toddler, this is somewhat disparaging language. And we've also removed information that has no basis around schizophrenia and bipolar disorder that is not a diagnosis that a physician has given. And we've also removed irrelevant and stigmatizing information where it doesn't relate. And also removed quotations that are not relevant. So both quotations from Mr. Jackson, but also removed the quotation of Ms. Roberts, who said, I ain't gonna do it. And this is something to consider. Of course, we do want to be able to portray as closely as possible what the patient said in the chart note. But just because something is a quotation doesn't mean that it has now been represented neutrally or objectively or faithfully. Here's a recent, here's a quote actually from Beach and Saha in their recent article. Scale quotes are pernicious because there may be an insinuation of disapproval, sarcasm, or skepticism, yet the writer maintains plausible deniability. That is to say that when you are quoting someone, when you're quoting your patient, this is still a choice about framing. This is a choice of which of the many things that they may have said are you choosing to quote? Are you choosing to emphasize the accent? And with the removal of her quotation, it's intended, I removed it because it might imply kind of disparaging tone towards her grammar, her accent, or her education, which then can say something negative about her that gets repeated throughout the chart. So documentation, it's not that the more the better as far as documentation is concerned. Sometimes adding documentation can add error if that information is not correct, or if it's misleading, or if it's judgmental. So when you write something, ask yourself, who's providing this information? Where's the source of this information? I'm sure we've all read notes where there was some kind of rumor basically in the chart, and it took days or weeks to figure out that that was totally wrong, and it misled the medical team into providing recommendations that were not in line with what the patient would benefit from or what the patient would want. So could the person providing this information be biased? And what is the purpose of documenting it? Is it to help make better decisions, or are you documenting this out of a frustration? Are you trying to express your annoyance with the situation? Making sure that we're not doing that. It could just be misinterpreted the way I've put this. And importantly, how can this chart note contribute to vulnerability? So this requires being aware and sensitive to bias. So something like the label of mental illness, that can be stigmatizing because it can suggest the patient is violent, difficult, oppositional, non-compliant. So it already sets someone up against them and makes it more likely that there's going to be further bias against this patient. So we want to reduce contributing to this patient's vulnerability through our chart notes. Okay, for case 3, Mrs. Delva and baby A. So Mrs. Delva is a 24-year-old African-American female, 3 weeks postpartum, with a history of drug use during pregnancy. She skipped prenatal visits, claims to be Muslim, and won't come to the NICU to see her baby. She insists on continuing aggressive care despite discussions with the team regarding futility. Okay, so what does this say about her? What kind of mother is she? Is she a bad person? Is she a bad patient? What do you think it'd be like to work with her? So this is potentially, again, painting her in a really negative light. So let's see what happened behind the scenes. So she actually identifies as a Haitian immigrant, not as African. And so I guess someone just looked at her and decided, here's her ethnicity. And she's never been married. So the label there that she had, Mrs., was inappropriate and might actually be just an assumption made that a woman who's pregnant ought to be married. And she missed some prenatal visits. This was due to her abusive partner. And she used marijuana during her pregnancy to help with her depression. And unfortunately, she overheard the day nurses saying that they had doubts about her piety because of her use of drugs. And so to avoid having to encounter these people, she stopped visiting the NICU in the daytime and only came at night, which is what led to these notes about her not coming. She ultimately actually wrote a letter to the hospital about this experience and how she felt discriminated against by the staff, which is a really horrible situation for this person who already has this child that is dying, and now they feel this extra layer of discrimination and isolation during a really stressful time in their life. So how can this note be better? Well, first we can give her the correct title. Ms. Delva is a 24-year-old female. And we don't necessarily have to place her race up front. We could say that she's a Haitian immigrant. Is that relevant here? Is that the thing that we want to have first and foremost? Studies have shown also that when people are white, their race doesn't get reported as often. And so having a report of race can already be a kind of a factor that can increase bias. And she identifies as Muslim. So it's true, we're not questioning or casting doubt on her religion or her religiosity. It's true that she identifies as that. And she has various prenatal care, but emphasized commitment to her baby, which is from the conversation they had with her. She did express this, that her reasons are she's considering the best interests of her child. And she says her request for full care for her child is based on her religious conviction. So it'd be good to say more here. Like, just because someone is Muslim doesn't mean that we know what that means in terms of how they understand their faith with regards to medical decisions. So it'd be good to say further how her faith relates to this conviction. And from conversations with her, it sounds like she believes that not going with full care would lead to her and her child being condemned. And I have not seen her during the day shift today. So being accurate about exactly what you saw and not making assumptions about whether she comes or doesn't come around the time that you don't see her. And also here you'll see that I've changed aggressive care to full care. And this is something where, we use these terms all the time in the medical chart: non-compliant, aggressive care. And aggressive care often is used in a sense to suggest this person is being unreasonable. Oh, they want to take the most extreme, they're extremists in what they want. And so it's kind of judgmental of their decision. So here it's a change to full care. And also the information about her abusive partner was not noted here. There might be a better place to put this in the chart note, somewhere more restricted or along social work notes than upfront when we're dealing with this case. So negative descriptors, which is something we've kind of been seeing here, are terms like non-compliant, agitated. They have a negative connotation, and recent studies have found that Black patients, unmarried patients, and patients on Medicare are are 2 to 2.5 times more likely to be labeled as negative descriptors. And this is really concerning because patients with negative descriptors experience more negative attitudes toward them from providers, and they receive less aggressive management of pain. Moreover, patients who feel discriminated against, this is an earlier study, if they feel discriminated against either by their direct from their provider, or let's say they're reading a chart note, they're less likely to follow their doctor's recommendations. So not only might that lead to worse health outcomes, but then when they come back for follow-up and they're being non-adherent, they're going to get another note that they're not adherent. And so what you end up having is this cascade of bias, this increasing number of not only from the patient, but also once that one note is in there, this can taint the record and lead to more negative descriptors put in the chart notes, more negative bias from both the current team and anyone into the future who reads this note, which could follow the patient around for years. So this is why these kind of negative terms, and even when they're really subtle, can have a huge impact. And particularly, when you do intake, the first person who writes up that full story of the patient has to be especially careful. So what are some mitigating strategies? So here I have a table. We cover a lot of these terms. I found this kind of to be handy. So terms that are often used, agitated. So rather than saying that the patient is agitated, which is sort of a negative descriptor, be more specific and be more reasonable if you think that's appropriate here. So what does it mean to be agitated? Well, in this case, maybe it's the expressed annoyance with having to wait a long time to be seen. So we're giving a specific reason and a more specific behavior. Difficult patient. Again, specificity would be better. It's very unclear and vague what difficult means, besides just kind of giving a negative impression of the patient. So has the patient declined treatment? Is that making them difficult? Or have they been dissatisfied with their care? Have they been expressing that? Or have they been experiencing manic episodes? Is that what's making them a difficult patient? So be more specific. Terms like frequent flyer. This is a disrespectful term. It's using a kind of jokey language that is not appropriate. And so it's better to be concrete about it. Have they had multiple admissions for this issue? Or has the patient had multiple admissions this year? What are you referring to? Instead of insist on, you can use a less judgmental term such as has requested. And patient is not compliant. Rather than that, you can use terms that carry less blame towards the patient, such as has barriers to compliance, namely, and then being specific about what those barriers are. Patient refuses treatment. A less judgmental term is has declined treatment. So every patient has a right to decline whatever treatments are offered to them, and saying they refuse it kind of suggests that they should have taken it, that you think they should have, and that they're doing the wrong thing. And substance user, instead of substance user, we want to use language that avoids diagnosis first language, such as drug-addicted patient, congestive heart failure patient, or obese patient, as it's dehumanizing. And we want to instead replace that with person first language. So has substance use disorder. Now, this might vary a little bit depending on the community they're from, but these are just sort of general recommendations to think about. Okay, and here's a summary of some of the strategies we talked about. So include relevant social determinants of health that might be impacting the patient's care and adherence, so as to sort of recognize where they are doing the best they can, but they have a lot of barriers coming up against them. and give the reason, the why the patient disagrees, or the patient is non-adherent, or the patient has made a certain decision. This really helps provide more of that context and allows for better advocacy for the patient. And if you can, also include positive and encouraging comments that emphasize the partnership that you have with this patient, because we tend to focus mostly on the negative that stand out, but there's also going to be ways that this patient is adhering to or doing things that can be recognized in this chart. Write chart notes with the patient. This is from, especially recommended by Dr. Laura Dietrich-Grimes. Sit down when you're writing the note, if you can, and write it with them. And if that's not possible, then at least do it when you are writing it. Write it with the assumption that the patient is reading this chart. And you know, sometimes there are certain things that have to be documented for insurance purposes, for example, and just explain that to the patient. Let them know that, you know, I'm sorry, this is the kind of language we're going to have to use in your chart note, but I'm just letting you know. So, for example, it might be the case that to make your patient eligible for PrEP medication, you might require writing that they engage in high-risk sex. And the patient might kind of object to that, but if you explain to them, well, this is why we have to write that, that helps allowing them to understand why those labels are in their chart. And if there are things that you need to communicate that are potentially stigmatizing, could be misinterpreted, you're upset about something and that's why you want to put it in chart note. Go and talk to your colleagues in person, or if you need to write it in private chat with the providers to make sure that this kind of sensitive information is not being disclosed widely, and also you know, just watch your attitude in general, because whatever attitude you have about your patients is then spread through the team, and you don't want to portray a disrespectful attitude about your patients. And lastly, be wary of copy and paste. So if you see, you know, of course, there's going to be sometimes long chart notes that we don't want to have to rewrite the whole thing. But if you're seeing that there's like negative terms, this is negatively portraying the patient, this is your opportunity to advocate for your patient by rewriting your own narrative rather than copying and pasting something someone else has done. Because this can really continue to multiply and then really affect how people see this patient. Okay, so my conclusion, of course, that we've come to is that attention to the chart note practice can reduce bias, and it might improve patient care and outcomes. And let me just say that if you have an ethics situation, something that you're not sure about, you're feeling this is, you'd like some ethics support, you can put in a consult through Epic. This is a new thing we've just rolled out recently. You place an order as you would place any other order. The thing is, if it's urgent, you should call the operator, and the operator can put you in contact and go through this like network we have to make sure that the right person gets in touch with you. But for just kind of routine things, then you can put the request in through Epic. And the plug for our symposium, our ethics symposium coming in February, we'll be asking to deceive or not to deceive. Is that even a question? So do you face that in your work? Questions of deception of elderly, deception of children, and other times when cultural factors are coming in play as to whether or not it's appropriate to lie to patients. It's much more complex than it might seem superficially. Of course, I would never lie to my patient, but yeah. So we'll be discussing the complexities of that question come February. That's actually a Thursday, not a Wednesday. That's the typo. And here are my references. And I'd be happy to take questions, but also would really love to hear about the kinds of ethics issues that you are facing in your practice. Before this talk, I did a little bit of review of literature and found that there's actually very little written on ethics in family medicine. And so if there's something that you are encountering, I'd really love to know. You can email me or you can share it today. Thank you.
Thank you, Olivia. I think you covered a lot of things that probably we have all seen and not necessarily put a second thought to. So a lot of this is just increasing awareness and trying to improve our eyesight and our thought process behind catching those issues. So one of the things, this is sort of a two-part question for me. One of the things that I was taught in a risk reduction class probably 15 years ago for my malpractice insurance was the most difficult patients that most providers run into are those that that are doing things that are against your family of origin rules. So like in my practice, if I came across someone that that either was dishonest with me or did not work hard, those were two things that were highly valued in my family growing up. And so those would be the most challenging patients for me, that patients who were dishonest or didn't work hard. So part A and part B, A, is that still, do you believe that that's true and that's still the case, that probably my implicit bias and my unconscious bias is probably going to be towards those patients most frequently. And then part B would be, if I make myself more aware of that, just like the conference that I went to for risk reduction, I was like, oh yeah, that really is the kind of thing that sort of sets me on edge. And I'm more aware, does that help reduce my risk of bias in my charting and just in my interaction with the patient?
Thank you. Thanks for sharing that in such a interesting personal note. Absolutely. I think that we all carry these kinds of values, and it's interesting to think about it, like how does our childhood impact how we're currently engaging with the patient in front of us? And absolutely, I think some internal reflection on what are the kinds of patients that you find especially frustrating. Because what does difficult really mean, right? That's why I was like, difficult is this broad term that doesn't really tell us a lot. And so it'd be good to introspect and ask yourself, which patients do I find difficult, frustrating, challenging, and how am I basically projecting this onto my patient, and then letting that leak into my note. And as the study seems to suggest, maybe we can't catch all of our implicit biases in terms of how they end up affecting our behavior. But there does seem to be some evidence that being able to, we can think about our thoughts and we can alter and catch them. And certainly in a chart note, you can have one chart note or a different chart note. I mean, you can have, you have a choice about how you're going to write that. And so once you become aware of it, I think you can improve it. And we'll never really know the full extent of the impact on someone. But I think, there's also updated information and terms change. And what used to be considered not offensive or not judgmental is now offensive and judgmental. And that's normal. That's just how language changes. And as a society, we're kind of coming to terms with these different kinds of notions and just trying to stay abreast of that and respectful and doing our best in that regard.
And I think there's a misperception that if I am judging someone and the person that I'm judging is different than me, a lot of people make the mistake of deciding for themselves what should be and shouldn't be offensive to that person. And if they don't have that perspective, they don't have the ability to decide what's offensive and what isn't.
Yeah, that's interesting. Right. Yeah, we don't know at the end of the day. Someone might not find that offensive. And it's not just about, is the patient reading it going to be offended? Because they may not be, and they may never read their chart note. But it still might taint something that someone else might read it in a certain way. And to the extent that we can sort of control obvious things, sort of like patient demands versus patient requests, there is a different tone. I think that we can focus on those things. And yeah, there is this and kind of, there's a lot here that is outside of our control.
So we do have a couple questions in the Q&A. First one is, non-compliance is an ICD code. Why wouldn't it be appropriate to write it, patient is non-compliant in the note?
So yeah, so this is another example where if it's a requirement for you to write it, then you have to write it. But this is an opportunity to discuss this with your patient and say, hey, here's what your chart note is going to say. It's saying that you're not complying with this. I have to write it this way, but we can also add to it. Here are the things you are compliant with, so you can kind of balance it out. And why is that not okay? Well, it's not okay because having just that in the note can create this sort of negative association with this patient. And so we're trying to mitigate that or reduce that as much as possible, while of course following all of the requirements for codes and insurance purposes or whatever that you have to write.
Then the next question, so the question, trying to read through it, basically, why is it not appropriate to state that someone is refusing their child's vaccines if that is a totally accurate statement?
So this goes back to, it's appropriate to say that let's say they're declining, they don't want it. Now refusing, again, has this connotation. And, there's a lot of ways to describe the same event. There's different possible language. And when you're saying refusing, you're most likely, you're giving the sense that you don't agree with their judgment. There would be another way to write that, potentially. If you agreed with them, you thought, yeah, I wouldn't give my kids that, I wouldn't take that. And you might write that in a different way. So all of these, this is your choice. You can choose to write your chart notes the way you want. But you need to be aware that writing them in a certain way just gives certain judgment. And just because it's true, even when it's a quote, even when you're quoting a patient, they verbatim said this, that doesn't you're not off the hook now in terms of how you frame that. You have a lot of power as a physician, as a provider, for framing that story. And that story gets portrayed in a certain way depending on how you write it in the chart note.
Okay, so another question's popped up. Is any of this education presented or provided to new staff members starting at Norton Healthcare? I think it would be helpful to show them the correct way prior to charting on patients, or maybe do we have an LMS module for this?
As far as I'm aware, this is the first time I've rolled out, well, I'm aware for sure that this is the first time I've rolled out this presentation, and this particularly for family medicine. But that if it's something that is well received, then potentially it's something we could talk about for new employees. So thank you for that suggestion.
And just so that everyone sees, McKenna just typed a note that this session is being recorded, so it will be available for anyone to watch through our CME website. So given the questions that we've had, and then also the context of your presentation, do you have any parting thoughts or words or anything other than I do know from our interactions that you are a great resource from ethical standpoint, and and really provide a great voice to look at things from the view of an ethicist, which, even though all of us have had ethics courses, don't have that depth and breadth in the background. So, any parting thoughts?
Not even regarding just this, but I've been at Norton now for 1 year, and I've kind of gone around and try to get a sense of what the community is like. And I really do feel that providers at Norton Healthcare do really care, and they do want to do the right thing, and they do want to do the ethical thing. And that's really important, because it's hard to inculcate that kind of attitude. After that, it's just a question of refining and trying to figure out what are my practices? Are they reflecting these kinds of values that I want to uphold, or are they not? And these are just considerations for you to try to see. Maybe this will challenge you to see if you can write a note that maybe is different than what you're used to. It might take a little more effort, and it might take a little longer, but it might actually really positively impact your patients. And often the patients that are the most difficult are the patients with also the most difficult lives. And so there's a lot here that we want to kind of avoid making that worse. So anyway, this is to say I'm really proud to be here, and really pleased to be working with everyone. And if there are issues you're encountering, please do send me an email. I would be happy to chat, come by, or just be aware of what kinds of ethical issues are common for you. Thank you.
Thank you, Olivia.